The title of my talk is the role of markers in diagnosing prostate cancer and contrasting it to MRI. We've come a long way in the diagnosis of prostate cancer in the last 4+ decades. It wasn't that long ago that we were diagnosing the disease by rectal exam, and you can imagine most of the cases when we found them were advanced. Along came PSA. PSA really opened the door to a lot of opportunities, and in spite of what's going on right now, it's still one of the best tumor markers around. But along with it came the challenge of overdiagnosis and overtreatment and missing cancers, and we're fortunate to have a lot of new tests and markers and MRI, and so I'm going to take the role of markers, but I also will talk about MRI. So the first thing is, when I talk to a group of urologists and I ask those listening to this what you think, are you really satisfied with the current state of early detection of prostate cancer? And I can tell you from meetings we have done that whether we ask people to raise their hand or vote, that not many people are happy with the current state of early detection. So we've got to take a fresh new approach to this, and I'm going to talk about the use of markers, but let's talk about some basics first. PSA is a very good test to identify the relative risk of prostate cancer. I think it's PSA is what we want to do is throw out a big net and let the little fish get away and catch the big fish, and PSA is a good test to identify where to throw the net. But we have to understand PSA to begin with. Urologists are surprised to see that in a couple of studies that have been done, that 90% of the PSAs that are ordered by family practice and internal medicine. And here's where we got to start. We got to start with these guys and ladies and talk about educating about prostate cancer and screening. We know that we confuse the heck out of them. We talk about PSA velocity, PSA density, age-specific PSA, and we have all these different markers, percent-free PSA, complex PSA. We have 4K score, we have SelectMDx, and they go, oh my gosh. Well, they need some simple message, and the message I have is 1.5. How did we come up with this? We took a group of 21,000 men who were part of the Henry Ford database, and what we did is we looked at the diagnosis rate of prostate cancer over 5 years with a PSA cutoff, and we found out that if your PSA was less than 1.5, so you were down in this area right here, that your risk of developing a prostate cancer in 5 years in this database was 0.5%. And most of those were not significant prostate cancers. However, if you were 1.5 to 4, not just above 4, but 1.5 to 4, that what we find out is that your risk of prostate cancer increases substantially. So what we say is that 1.5 to 4 is a danger zone. It's not just the risk of prostate cancer, but also BPH and other things, prostatitis. So a PSA of greater than 1.5 to 4 is the most common cause is BPH. And as we know, we have looked at the PSA levels and sizes of the prostate. As your prostate volume increases, so does your PSA. It's also a surrogate for prostate cancer, and there's where the money is to try to find out who has prostate cancer, but we want to be more specific than we were in the past. We want to find out who has significant prostate cancer, and that's where I think markers play a role, and I'll talk about that in a minute. We don't recommend biopsying everyone with a PSA greater than 1.5, but we want to evaluate them because they're in the danger zone. Maybe it's just BPH, and we can follow them or repeat the PSA, do AUA symptom scores, but if we're concerned, this is where PCMs or prostate markers come in to help us here. So one of the first criticisms we hear is, oh my gosh, if we say a cutoff of less than 1.5, is something to worry about. We're going to have a lot of men that need to be evaluated. No. We looked at over 400,000 PSA tests, and what we found out that in this group of men, and it was a group of men with various ages, but in general, that 73% of men had a PSA of less than 1.5. And so what does that mean? That means that you have, here's this 1.5 to 4 range, that about 20% of men fall into that, and then the rest of them are above 4. And so what we have laying at our doorstep here is about 20% of men have a PSA of 1.5 to 4 that we want to think about evaluating. All right, so I've already said this, as the PSA goes up, so does the risk of prostate cancers. This is something we had in the journal about 15 years ago from the MTOPS trial showing the relationship of prostate volume to PSA. So it's a good surrogate to judge your PSA. Your size of your prostate, which is also good too, because we know that as the prostate size increases, so does the risk of urinary symptomatology in general. We published this article in Urology a number of years ago, about 5 years ago, on the using PSA 1.5 as a cutoff for family practice doctors. That's where we got to start. So I want to finish up talking about this diagram that we put together, because it's sort of all here for us on what we want to look at. So this is sort of a journey a man can take. We have a guy come in to see his doc, and he has a 10-year life expectancy. He's probably over the age of 45. Then you do early detection efforts, and the early detection efforts are doing a PSA. And if the PSA is less than 1.5, then you go back into and repeat it in 5 years. If it's greater than 1.5, then what we have here is a gray zone. And as I've already said, you evaluate the patient for BPH and also worry about prostate cancer. Also, the other thing that's come into play here is germline testing. So we want to know if people that have family histories of prostate cancer, breast, colorectal, things like that, Lynch syndrome, and so forth. And we have markers that help us. We have the Myriad MyRisk and the Ambry's Prostate Next. And then we have studies that look at SNPs and so forth, and this is the prompt test. And so now we have the patient who is in a gray zone. So we don't necessarily need to do a marker. If we think this is BPH, we can do an AUA symptom score, repeat it in 6 months or so to see what's going on. If we're worried about prostate cancer, we don't go to a biopsy. What we do is we do a genomic test. The one that we use the most is SelectMDx. And this test has a great negative predictive value, 98% or so, that if the test comes back negative, you don't have a significant prostate cancer. The name of the game here is not to find prostate cancer that's low risk, but to find high risk prostate cancer. And this is where the markers are very important. One could argue that MRI is helpful here, and it is, but I think MRI can fit in later. And there are some studies that are out there looking at combinations of markers with MRI, where the markers are what determines when to do the MRI. So if you do these tests and the test comes back low risk or negative, then you repeat it in a year. If it comes back high risk, then what we do is that this is a patient that goes on to a prostate biopsy. Now, a couple of things can happen when you have a prostate biopsy. You can have a significant cancer greater than 3.4 or I'm sorry, Gleason 7 and above. You can have 6s. If you find a 6 and you're thinking about active surveillance, we do have markers that are helpful to determine that whether you should watch this or not. And we have some pretty good evidence right now that if you're going to go on the active surveillance bandwagon, then in addition to these markers, or if you don't do the markers, you should do genomic testing to make sure that you're not, you don't have a DNA repair defect that would make it high risk for active surveillance. And then if it's positive, what we do, and that's Gleason 7, we'll obviously consider treatment. What about negative? Well, that's a problem. And you biopsy people because you think that they have prostate cancer. If it comes back negative, what do? Well, I think what you do is as a ConfirmMDx, which is another marker which is important. This one looks at sort of cancerization or epigenetic changes that occur around the cancer. It sort of magnifies and increases your zone of your biopsy. And if that test is positive, here's where I think MRI is helpful on the and determining where to biopsy and so forth. We also do mapping biopsies and repeat ultrasounds and things like that. And there's a thing called a micro ultrasound out there right now. So all these things are important. I think MRI has a role, but my opinion on where MRI is that sort of that it falls in right here after these sort of tests are done, molecular markers. So with that, thank you very much.